Our next speaker is Dwyer. O'Mary serves as a clinical ethicist at University Hospital's Case Medical Center and Rainbow Babies and Children's Hospital. She completed her law training at the St. Louis University School of Law and obtained her Master's in Arts and Clinical Ethics at Case Western Reserve University School of Medicine. Please help me welcome O'Mary Dwyer.
Thanks, Kayla, for that introduction. Good afternoon, everyone. All right, I see there's still a few more people who are making their way to their seats. So today I'm going to talk about non-beneficial treatment. This is, of course, a controversial topic, so if you guys have any questions along the way, definitely feel free to interrupt me, okay? So in this talk, I'm going to go over the various definitions of non-beneficial treatment. Have you guys heard that term before, non-beneficial treatment? It's also known as futility. You guys have heard of futility, of course. Yeah, okay. So as an ethicist, I definitely don't like using that word because it's a mushy word, so we always are try to be specific about saying that the specific treatment is not beneficial to the patient. So talk about the definitions of that. We will also go over the statements of the professional societies on this issue. And we're also going to talk about the limits of autonomy, especially parental autonomy, because I know that you guys are all work in the world of peds, and that is an issue that definitely comes up when we talk about non-beneficial treatment, and we want to go over how we're going to manage that conflict when we are confronted with it. So as we go over all of these points, I'm going to be telling a story about one of the first cases I had in the peds world dealing with non-beneficial treatment. Okay. So I was the ethicist on call who was called on day 12 after baby boy PJ was born at 30 weeks gestation after loss of fetal heartbeat. At birth, he had an APGAR score of 0 at 1 and 5 minutes of life. He did not have a sustained heartbeat until the 7th minute of life. Since birth, there has not been any spontaneous respirations or movement. An EEG was performed, and it was determined that he had severe encephalopathy, and that treatment would not reverse the patient's condition. And so, since we were called in on day 12, there had already been ongoing discussions between the team and the parents. And the first thing out of the mouth of the medical team when we were called, you know, they said, we want to do our best. We've been trying our best to preserve our caring relationship with these parents. But they seem to be under the impression that since they're the parents, they get to decide whatever they want. They get to demand anything they want. And of course, these parents are demanding for us to continue treatment. So a little bit of background on this family. Mom and dad are both Muslim. Mom had not gotten any prenatal care before she presented to our hospital. They both live with the dad's mom, and so grandmother, dad's mom was very much the matriarch of the family and kind of took over all the meetings that the team was trying to have with the family. And so the doctors were asking, you know, we want to preserve this relationship with this family. How do we go about this? You know, just because they're the family, does this automatically mean that they get to trump whatever we determine to be appropriate? And so one of my colleagues who she widely proclaims that she does not do pediatrics. She tries to stay away from pediatrics as much as she can. She's like, I can't handle dealing with the kids. Can't do it. So she brought up to me this quote: a physician-patient relationship, like any ethical relationship, is a reciprocal relationship. In the justifiable concern for patient autonomy, we must remember that a physician is a moral agent, as well as the patient. When the two are in conflict, the patient's wish does not automatically trump the physician's. And this is true no matter if you're in the adult world or if you're in the peds world. Now, I know this quote says physicians, but this relates to any care provider feeling or involved in the caring relationship with a patient and their family. So we look at this quote, and the attending's like, okay, I totally get that. But still, how do we preserve this relationship with the family where we really don't think it's appropriate for us to continue treatment for this baby? And so he said, well, let's turn to professional societies. Maybe they provide some guidance. Now, I know up here we have several of the adult-leaning societies because there aren't a lot of guidance that's provided in the world of pediatrics about this issue. Has any of you guys come across any guidelines in the peds world that talks about non-beneficial treatment or futility? Anyone, just by show of hands? Just policies. Just regular policy, but not like, this is how you have the conversation. Nothing like that. Exactly. But in the adult world, there are policies and clear guidance statements about how to deal with this issue. And so the doc is saying to me, and also the rest of the team, because believe me, I was hearing from the nurses as well saying, oh my God, how can I continue providing care for this baby who, you know, if not for him being a 30-week gestational age, we'd be saying this baby is dead by neurologic criteria, but we can't say that in this situation. So no guidance by these societies. So what should our next steps be? Okay. So we look at the various definitions of this situation. You know, which definition of non-beneficial treatment actually applies for this child that we're taking care of? So we looked at medical judgment, and the attendings, the neurologist, and the NICU attending was saying, you know, we definitely think it's medically inappropriate for us to continue the full life support that this child is on. We have not started dialysis, but we see that his kidney function is declining. He's on respiratory support. But none of these treatments are going to fix the underlying condition, which is what mom and dad want. So at least from a medical judgment standpoint, it's not going to make a difference here. And then the neurologist said, well, even more specifically, he has no ability to appreciate any benefit of what we're doing. And I said to him, how do you know that for sure? And he turned to me and he said, there has been CT imaging that shows that there is I can never get that word out, liquefaction of his brain. And his brainstem is obviously severely damaged. So we know that or at least we are pretty sure, at least 99% sure the neurologist as sure as the neurologist can be, that he cannot feel any pain. He's not going to appreciate any of the benefit of the treatments that we're providing him. So right off the bat, we have two definitions that we can apply to this situation of, you know, this is how futility or non-beneficial treatment applies to this child. So what would we do? So we have our definitions that clearly lay this out to us. So what is our next step? Do we just go into the family meeting and show these definitions to the family and say, look, your child fits two of these criteria, so then we're justified to turn off all machines for your child? Do you think that's what we should be doing in a case like this? No, definitely not. I have seen that happen in other family meetings, and it does not go well when that happens. So said, yes, let's keep that in the back of our brains that we have two definitions that definitely apply. There are probably more, but at least these are the two that easily apply to the situation. So what do we do next? So we have our definitions. Now we want to look to our standards because we want to make sure that we're not deviating from what's medically appropriate for this child. So we're dealing with a situation where we're going to have to basically limit parental autonomy in this case. And so me being a lawyer, they of course turn to me and say, are there any legal cases that kind of apply to this case? And I said, no, there really isn't. You know, law is not the answer here. Like, I know that people like to ask what's legal, but remember, I'm the ethicist here. You know, I can't tell you from a legal standpoint whether or not this is okay and what you should do. You can definitely call legal for their advice, but all you're going to get from them is advice. And so they went ahead and called legal, and legal says, well, you know, we have this Prince v. Massachusetts case that says parents may be free to make martyrs of themselves, but it does not allow them in identical circumstances to make martyrs of their children before they've reached a full age and legal discretion to determine whether or not they want to be a part of that religion. This case was about parents who were using their children to, I believe, distribute the Hightower. They're Jehovah's Witnesses, the Watchtower pamphlets. And so the court was saying basically that these kids haven't chosen to become Jehovah's Witnesses themselves yet. They're not of legal age to make that determination, so you can't use them to be doing this. And so I said, okay, that case kind of applies, but this is in a situation where the parents are refusing something on behalf of their child. That's not exactly the situation that we're dealing with here. This is a family that's demanding that we continue doing things, not refusing, they're demanding. So I'm not sure how exactly that applies in our case, but okay, let's set that aside. And I said, this is an example of why legal, not so helpful in this situation. And so we looked at and said the best interest standard, because that's what we usually do, at least from an ethics standpoint, and how we determine what we should do for a child. We look at the best interest standard. And so in applying that standard, we always want surrogates to maximize the benefits available to the child and minimize any harm that could happen to them. And you want to keep in mind the holistic views of the patient's interests. And of course, we have to use the parents to determine that, especially in this situation. When we're dealing with a 17-year-old, things are slightly different. But when we're dealing with a baby, we're completely reliant upon the family, the parents, to tell us this. And so the team is like, okay, so if we apply this definition that he can't appreciate any benefit, but there is still some benefit to us keeping him alive, even though he can't appreciate it. That's what the argument the parents are going to have. At least that's probably their perspective here. So what could be our counter-argument to what they determine to be in his best interest? And so we looked at the harm principle. Have you guys heard of the harm principle before? I see a couple of nodding heads. Yeah. All right. So the harm principle, very simply, we want to identify a harm threshold that's below which parents are allowed to make decisions that, that the harm can't be so high that it shouldn't be tolerated. So for this kid, we'd gotten to the point that he was on artificial nutrition and hydration. He was on the vent, and 2 months had now elapsed. And because of the fact that we were basically forcing nutritional hydration into his body and his kidneys weren't functioning, his body, of course, wasn't processing the nutrition properly, he'd become very edematous. And you can start to see splintering and blistering of his skin because we were forcing all these things into his body, and it just is not processing it. And so the team was saying, we are really starting to show, or his body is starting to show us signs that the treatments we're providing really are starting to cause harm. It's no longer providing him benefit, at least from our perspective. The family will see it as he's still alive, and so he's still getting benefit from it. But our counter-argument here is that it's also causing problems for him. And if he had an intact brain, he most likely would be in pain as well. So now it seems like we're at a deadlock right now. We have the best interest standard pitted against our harm principle. So what do we do? All right. So we said, let's just put that aside, and now let's focus on parental autonomy. All right. So a lot of people think that when we talk about autonomy, that this automatically means that the patient gets whatever they want. And that is not true, because we often have situations where patients and families, they come in requesting for us to do things that are not appropriate for a patient. And so it is our responsibility to say to them, given your diagnosis, these are the things that we should be doing for you. And what you're requesting here is not appropriate for what you're asking for. Because we ourselves, as care providers and actually as human beings, we're moral agents too, and we have the right and the authority to be free of the influence of anyone else. And the same can be said for parents. Now, a lot of people say, well, that can't really happen because parents are seeking our help. And when they're seeking our help, they're somewhat giving up a bit of their autonomy and allowing us to exert our personal autonomy over them and providing care for either the patient or for their loved one, depending on the situation. Now, the one place where we don't cross over when it comes to autonomy is when they have the absolute right to say, I don't want you to be doing things to me. That's the one time that we can't force someone to do things, okay? So as an ethicist, we always describe this as a negative right and not a positive right. So what we mean by a positive right is that it's when people come in demanding things, and people can't do that, but they do always have the right to refuse things. But again, not a situation that we're dealing with here, because the family isn't refusing things, they're again demanding things. So autonomy, while it's there and it exists, and the family, of course, has the right to demand things, but we are under no obligation to provide it, even when it comes to pediatrics. And that is a hard thing for a lot of people to take, because they're just like, well, you know, we're caring for a child. Of course we should do anything and everything we can for this child, especially when we have parents who are very concerned with making sure that we do whatever it takes to keep their child alive. You know, how do we not do that? All right. So then we look at family-centered autonomy. So clinicians must balance the need to work collaboratively with all parents and families, respecting their cultures, religions, and the importance of the family's autonomy and intimacy, with the need to protect children from serious harm serious and imminent harm. So we have Muslim parents, and actually they were saying to us that the only reason why they're still demanding to continue treatment despite everything we're saying, because they're not disputing the fact that their child is neurologically devastated. They're not doing that. They're saying our religious beliefs demand that we continue everything. So does this now, because we're talking about religion, does this now mean that we toss out everything that we've determined for this child and say, well, because their religion says it, that means that we automatically do it? What do you guys think? No. That's right. Now, we definitely take it into consideration. We talk about different ways that we can alter the things that we're doing to help for the child. Because another case that I had, we actually allowed the parents to bathe the child, because it was part of their culture to bathe the body after death. And so we allowed that. We don't normally do that, at least at that institution. They didn't normally do that, but we changed our protocol for that family, recognizing that that's their cultural belief, and that's what they do when a loved one dies. But that, we can't exactly do the same thing here in the situation. So what do we do here? Parents' authority is not absolute, but should be constrained by respect for the child. And that's the quote that really struck with our caregivers, because especially the nurses, they were getting to the point they were saying, I can't even turn him without the ET tube coming out. Like, I now feel like I'm personally disrespecting this child because his body is bloated. He obviously is not processing the things that we're doing to him. So how can I continue laying my hands upon this child and doing these things to him that I know is not helping him? So we're at this deadlock. We are balancing the patient and family's rights. You know, they're saying, you know, to them, non-maleficence is avoiding death. They're saying that they want to extend life at all costs. They want to basically continue treatment. And then we have a medical team that's saying, you know, and our definition of non-maleficence here to avoid harm to him is not extending his dying process. And in fact, in some situations, people would say he's already dead. We're just doing more things to his body. We believe that we should be just providing comfort to him during this dying process, and we want to stop treatment. So, of course, we now have this conflict. Luckily, you know, things didn't get to the point that we were shouting and screaming at each other, but it was very clear that we were deadlocked and we weren't getting anywhere with this family. And the family started questioning us as to who gets to determine whether the treatment is futile, especially when the probability of success is low. Is there any chance of success in this situation? No, there isn't. And the neurologist was very clear to the family, saying, we hear you that you want to continue treatment, but you don't seem to understand the fact that giving him artificial nutrition and hydration, continuing support, respiratory